All right, let me show this one first. I don't really know for sure what this person's symptoms were at this time, but this is a chest radiograph from March, and this is the lateral radiograph looking the wrong way. But let me go back to the frontal. And there is this large opacity, of course, in the basal right hemithorax. And you will see now as I scroll through that this is a large tumor. So when we get down here, we see that it's a large solid mass, somewhat heterogeneous in attenuation. There's some areas of relatively low attenuation within. There are also some vessels within, perhaps some neovascularity. Maybe here's a little calcification within, but otherwise a very large mass occupying a substantial volume of that right hemithorax. There are also some enlarged lymph nodes in the subcoronal region. So he did have a PET scan, and I'll bring that up alongside. So when we go through this, let me just go to the bottom here. You'll get a feel for how PET avid this is, which isn't that much, but there is an area there that is. Interestingly, these lymph nodes are not really PET FDG avid. And then up here is an unanticipated finding. So we have 2 nodules in the thyroid that are very FDG avid. And here is one additional small but FDG avid lymph node in that region. So how to put all this together gets a little bit hard. So think about how you would report that, and then think about how you would report the thyroid disease. So, of course, we need to go to surgery to see what this large tumor is. So I'll leave the PET there, and then I will bring up the result of the pathology. But certainly one should think of sarcoma, fibrous tumor of pleura, maybe a inflammatory myofibroblastic tumor, but in that range of tumors. So this one does turn out to be a solitary fibrous tumor. And let me just go back there. You can see there that it's got malignant features. And here's somewhat the surprise, that in this tumor, there is metastatic papillary thyroid carcinoma. So he has both of those simultaneously. So that's a real curiosity. Here are the description of those cells within the tumor, but he has metastatic papillary thyroid carcinoma as well. So this one was positive for so-called STAT6. I don't know too much about STAT6, but here's a brief description of STAT6, as well as its significance with respect to diagnosing this fibrous tumor of pleura. So it's one of the things that one could look for, at least pathologically, if this particular form of tumor is a consideration. So this person has 2 simultaneous unrelated tumors at the same time. So that was a surprise. All right, let me show you this one. So this person came to our hospital from the outside, and I really got to see this after this nodule right down here had already been taken care of. So a lobectomy was done for that, or at least, maybe not a lobectomy, actually I'm not sure, but at least a wedge resection. So this is March of 17, and the history that I got subsequently was that this was seen at the bottom of an abdominal CT exam, and it was further evaluated on a follow-up study. And this is the follow-up exam. So let me just get back to here to give you a feel for what this looks like. So on the left is March, and that's the 10th of April. So we really have like 21 days. And if you look at this, you can see that this nodule has increased in size quite a bit in that short period of time. And then if we look at this nodule, it has slightly ill-defined margins with respect to the lung. It's not a round, solid lesion with spiculated margins, but it is just what it looks like. So this person did have a PET scan, and the FDG, the SUV apparently was 1 point something, so kind of low. So I went to chestxray.com, calculated the doubling time at 11 days. So I'm really surprised that they would take this out, because it's something that's growing very quickly, much quicker than a tumor would grow. And based on its morphology, based on the FDG PET, this is, to my eye, very suggestive of a benign lesion. And if I had any role in this patient's management or consultation, I would have recommended a follow-up exam. So here it is. It is a small area of organizing pneumonia. You can see here that the pathologist described findings that are suggestive of aspiration as the cause of this. So organizing pneumonia. It also reminded me of this idea of organizing pneumonia producing nodules. So this is a CPC from quite a long time ago, in which the CPC had to do with nodules in the lung, as you can see there, that basically waxed and waned. So we had small nodules, they went away, new ones arrived, and ultimately that turned out to be organizing pneumonia. So the discussion was organizing pneumonia, aspiration syndrome, small nodules can simulate, as you can see there, metastases in that particular case. So I don't know how you feel, but I certainly would have recommended that this not be taken out, but it was.
Yeah, the PET was not, I mean, not necessary either.
Potentially not either, yeah.
Because you didn't have any prior imaging, right? It was just the nodule initially seen.
On abdominal CT. Yep.
Yeah, I'm a big fan of giving something a little time to see how it's behaving, especially because we have so much endemic fungus around here that, you know, histo can grow rather quickly, so can blasto, and you really don't want to resect it if you can avoid it.
Yep. I think that was really uncalled for. Okay, I'm going to show you a case that everyone will like, particularly the cardiac guys. So here is a person that came in that had initially a CT. And the history, I think that this finding that I'll show you was an unexpected finding in the context of, I think, shortness of breath in an older person. And then subsequently, this cardiac CT was done. So here is the lesion. I'll give you a feel for where it's located. So right ventricular outflow tract. Quite large in that location there. And I didn't really have time to look at all these MRI sequences that I have here, but Leif told me that this appeared to be in the right ventricular outflow tract. It was impeding some blood flow through the pulmonic valve, but otherwise appeared to be separate from the valve leaflets. And I can't remember what other sequences were done, so I'll let you have these when I send them out, but I can't remember if there were any other distinctive features about this. Actually, what is that sequence? You guys can help me with that if you recognize what this is. Is that...
Sorry, I think I was on mute. I think it just looks like a delayed
Yeah, I think it's a delayed. Phase sensitive inversion recovery, a delayed with some enhancement. Okay, so this was taken out. Any thoughts what you would go for first? Right ventricular outflow tract, something that it's an unusual location.
Yeah, it's too big to be a papillary fibroelastoma, I think. I mean, maybe a myxoma in a really weird location. He doesn't have a known primary?
Nope, nope. It is rather big, isn't it?
Yeah, I mean, you could always have a weird primary tumor, of course, rare, but I mean, maybe a weird location for myxoma.
Yeah, so those were the thoughts, but interesting, this turned out to be that. So this one has pathologic features of a papillary fibroelastoma. So I started looking at the locations, and of course, most of them are related to valves, particularly the aortic valve, but one can find case reports of those that are associated with just endocardium in different locations. And pathologically, that's what this one is. So you can see there that it wasn't really attached to the pulmonary valve leaflets, appeared to come off the free wall muscle of the right ventricle. They just took it out, and pathologically, it was read out as consistent with that. Isn't that interesting?
Very strange.
So it's rather big. Yep. And it didn't have the features, or at least the gross appearance of a myxoma, at least from the surgeon's point of view. Interesting. So I found case reports of these things arising from endocardium in different locations. So it can happen, apparently. All right, unusual. That's really interesting. Okay, Jeff, those are mine for now.
All right, thank you, Howard. Travis, you want to go now?
Sure.
All right.
All right, do you guys see my screen?
We do.
I'll start with this one. I've collected a few interesting ones since I haven't been here the last couple of weeks, but this is a lady who underwent a radiograph. I don't remember, unrelated symptoms, but you see this nice little lesion up here, and it has a couple of things that suggest pleural or extrapleural location. Number one, it has that incomplete border sign. It has pretty smooth and somewhat obtuse margins. This is a pretty interesting case, though, and the reason I'm showing this first is just because Howard showed that.
Yeah, it doesn't seem to be very attenuating for its size. I was about to say that it looks like it might be fat, but I turned out to be wrong.
Sure, right, that it could be a lipoma. Yeah.
Yeah, because I was thinking I can see the ribs. It doesn't look that attenuated, but it is.
And sorry, I should have mentioned too, right? Whenever you see this, I always, it's easy to overlook some sort of lesion arising from the bone or destroying the bones.
Yeah.
But this didn't have any of those features. You're right, it does look pretty low attenuation.
Yeah.
But this was the outside CT, and check out how hypervascular this is. And when one of my colleagues showed this to me, my first thought was this some sort of aneurysm arising from an intercostal artery? It's so bright. And it's interesting too that it looks almost like it's extrapleural, because you see some extrapleural fat around here. And so it's kind of peculiar. But at this time, the patient had been sent here to have it resected. They had done a biopsy at an outside hospital, and they gotten some sort of fibrous tumor, or they've gotten just some stroma that they thought was consistent with a solitary fibrous tumor. So my question for the audience is, has anyone seen a fibrous tumor that looks like this, or would you be thinking that?
That enhancing.
Not that hypervascular.
Yeah. I mean, right. I was wondering, or go ahead.
I was going to say maybe like a weird paraganglioma or something.
And that was my second thought. I mean, first I was like, wow, could this be some sort of aneurysm or pseudoaneurysm? And then, of course, they did an MR at the outside, and when I saw this, I thought for sure this was going to be a paraganglioma. It's got that little salt and pepper look to it. It's light bulb bright on T2. It's enhancing like crazy. And
if it was in a different place, I would maybe think of unicentric Castleman's.
Right, and of course, yeah, for the hypervascular, lesion. Certainly a weird unicentric Castleman's would be on the diff too. But anyway, they took this out, and it was not part of the visceral pleura. When I talked to the surgeon, he said it was kind of attached to the parietal pleura. It was, he didn't tell me if it was outside of the pleura or not, but it stains positive for the same STAT6, which is a marker of a fibrous tumor. Jeez. And so they're calling this a fibrous tumor. Now, I talked to our neuro friends who, solitary fibrous tumors and hemangiopericytomas are similar or one and the same. And I asked them how hypervascular they see hemangiopericytomas, and they said they can be. I don't know. This was surprising me, both on the location and the enhancement. But that's what they thought it was. And they don't really even comment on malignant potential of this tumor. I guess they do say here no significant mitotic activity, but just weird.
So, Travis, is the STAT6 positive in hemangiopericytomas?
I think so. I mean, if you look in the literature, hemangiopericytomas and solitary fibrous tumors are considered one and the same, at least to my understanding. And I don't know. I was hoping Seth was going to be on here, since he probably sees a lot of this at the AFIP and could clarify more.
The other thing, Travis, is that solitary fibrous tumors usually stain positive for CD34, which a lot of things don't, but I don't see they did that.
Yeah. So this was going to be presented at Tumor Board yesterday, and I was talking to one of my colleagues who was going to be there and just ask them how confident they were. I haven't heard back yet, but this was at least what it was signed out as at this point, based on the surgical path. So it still looks a little weird.
I think it's weird. I don't think I would accept the SFT. I've never seen a tumor this dense.
Yeah, I know, and it's right. And of course, they can arise from the parietal pleura, but most of them arise from the visceral pleura, and this is just, yeah. So the jury may still be out. At least at this point, they're going with that because of that STAT6, but we will see. Yeah, this one's a cute one for many different reasons. This is one of those cases that the more I looked, the more I saw, which is kind of fun. Now, this patient, and I don't remember why he was getting this done, but he's had some surgical clips here. He had a hiatal hernia repair at one point, and you can see his left hemidiaphragm looks elevated, and you can see even posteriorly, and it looks like there's some bowel gas lucency under there. So that's part of this case, and when you look at this, it's actually not an elevated hemidiaphragm, but it is a massive hiatal hernia here. And this is a patient that had esophageal cancer. So maybe it was esophageal cancer, not a hiatal hernia repair. But this all looks like it's just a hiatal hernia and not a diaphragmatic defect, as we've shown so many of recently. But you've got colon just resting here posteriorly. So that was the first thing that caught my eye and why I looked back at this CT, because I was just reading the radiograph. And you can see that it looks like it's all just coming through the hiatus here, that there isn't a separate diaphragmatic defect in this area. And you can see here, I think, is a good look, as it's continuous with the hiatus, even though it then just falls back posteriorly. So that's number one. And then number two, then I was looking at this, and I thought this was kind of interesting, that this caught my eye right here, and saw this in the left atrium, and was wondering at first if this was going to be just bland thrombus. But then looking here, you can see that he has soft tissue from the carina, and it's kind of contiguous, encases the right main stem bronchus. And this is several years out from his esophageal cancer, but this is a proven on bronchoscopy, proven as a recurrence of esophageal cancer. So I don't have a PET, but I'm assuming that this is probably tumor invasion of the left atrium here, giving you this. Now it could be a combination of bland and tumor thrombus, but that was kind of interesting. But then I noticed too, when I was looking back, and this was maybe the most interesting thing, is I saw this weird little blind ending thing right here. And it turns out that this is the cecum, and this is the first time I've seen an intrathoracic appendix. And it goes up to right along his left ventricular, along the mediastinum, along his LV, which is kind of cool, because then you can see that, this is cecum, that's base of cecum. And when you go down, you can trace out, actually here's the belly CT, and you can see that his cecum is nowhere to be found in his right lower quadrant. And so all of his colon, I don't know if this was malpositioned colon or if this was all post-op, but this is all of his colon plus his appendix that's in that hernia. So I just thought that was a little cute extra find, something I'd never seen before. All right, I'll show one more just because I've got plenty more, but I can show this one and then move on. I think we've probably all seen cases like this or shown cases like this, but it serves as a reminder. This is a man who is 54 years old, relatively healthy, has had a chronic cough, and was seen at an outside hospital where he was diagnosed presumptively with interstitial lung disease based on this CT. And I'm sure instantly, people are not necessarily keen on that diagnosis. He does have a little bit of funky cystic change up here. Some might argue it's some focal honeycombing, but not that that's really, the term doesn't really matter. He does have some fibrosis. It's a little asymmetric. He has these weird cysts too. But this was, he had been treated for multiple pneumonias, didn't get any better. I don't know if they did a bronch or not, but he eventually got referred to us after he had another CT several months later, where it was said that his interstitial lung disease was getting worse. Now we've all seen asymmetric interstitial lung disease. This is pretty profound. And of course, we took one look at this when he got here and said that this is going to be adenocarcinoma with just multiple different, stages and appearances with the, mucinous, the crazy paving there. He's got just cystic destruction of the lung, had some little airway, probably aerogenous spread in the left lung with these little centrilobular nodules, all of which had been there getting bigger. And so we did a CT guided biopsy, and this did come back as adenocarcinoma. So this is not the first time that we've seen adenocarcinoma misdiagnosed as an interstitial lung disease. So have you guys, I'm sure you guys have seen these kind of things referred into.
Yeah. Yeah, that's really interesting.
Yeah.
I wonder if the cysts in the left lung are separate because they're well circumscribed, just sitting here and there. And that may be something else like a Sjogren's syndrome.
Yeah, I don't know. And that's a great question. And that was going to be my next question. What do you think of these cysts? Because
yeah, I'm not sure. I'm looking for some in the right lung that look like that, but I haven't seen any. Because
that's not a morphology that we typically see with, that would be the one thing I would say is not a typical morphology of adenocarcinoma. I mean, maybe there were a couple here that have just been swallowed up and engulfed by all of this, the ground glass and consolidation. I don't know.
Yeah.
But Jeff, I'll stop there for now, and I can come back and show some more.
All right. David or Brent?
I'm ready to go if you got. So just a little blast from the past came through this week. Eric Stern pointed this case out to us, the Harborview patient who came in with these ectopic ping pong balls. And should be able to show you the lateral here too.
David, I don't see yours. Let's see. Wait. Never mind.
Got it?
Got it.
Okay. So this is the most pristine and most modern imaging, case of plombage that I've seen recently. So this is lucite extraperiosteal or extrapleural plombage, where they pack this in to an extrapleural compartment above the chest, above the lung. They didn't want to go into the pleural space, so they would peel the parietal pleura away from the upper chest wall. Sometimes they use periosteum of rib as well. They create a little pocket up there, and then they would fill that with different things to basically crowd the lung in and deoxygenate it so that the tubercle bacillus would decide to go away. In this case, they use these lucite plastic spheres. They could also use, as you know, beeswax or paraffin. That would be called oleothorax. But this is lucite extraperiosteal or extrapleural plombage. And let me show you this person here is a.
David, one question really quick. So those are hollow, the plombage balls?
Right. And one of the things you should look for in them is to see if they develop fluid levels, because that was a sign usually of infection. So sometimes if there was infection, it would actually erode into the ball, and then you'd get fluid levels, little lunules of fluid
Well, that one medial, that was going to be my next question. Is that a little fluid level in that one?
Well, I'm sort of wondering about that. Let's see if it's there on the lateral. I was thinking first that was just rib, but let's find it here on lateral. Do we see here we have a fluid level back here.
Yeah.
So good point. This may be then compromised and stuff like that. So I have a feeling they're not going to do anything about it, though. This person's, older, and unless they're symptomatic, they're probably not going to pursue that. As far as I know, this person was not radiographed because of chest symptoms, but I'll go back and look again because of this finding. Okay, so here's a person with a febrile illness and some weight loss, doing rather poorly, and has a pretty normal chest radiograph at this point, maybe a little bit of scarring down here or maybe a little bit of edema down there, and has a CT scan that doesn't reveal much in lungs, some atelectasis, and then we get down into the abdomen and things get more interesting. It turns out there are these very large adrenal lesions on both sides, extreme enlargement of both adrenal glands, and there are some probably abnormalities here in the spleen, and some low attenuation stuff in liver. It's hard for me to know whether that's just cysts. There's also some ascites. And so the presumption here was metastasis, and there was a needle biopsy. So a diagnostic procedure was performed. So,
is there any interstitial edema in the lung?
This person was described as having anasarca. So at this point, there's not much edema, if any.
Maybe minimal, but
yeah, small.
Wasn't necessarily thinking of pheochromocytoma or hypertension with cardiac.
Right. So this was biopsied, and the diagnosis was a huge surprise to me, but maybe not to Midwesterners. So do any of the Midwesterners want to speak up about what this might be? Yo, Midwestern people. Okay. So this was adrenal histoplasmosis. They grew histoplasma, and there was positive histoplasma in the needle biopsy. And here's the CT scan in this reported case of showing, again, bilateral adrenomegaly here. So it turns out that histoplasmosis can present with these big adrenal masses. Histoplasmosis evidently is a cause of adrenal insufficiency, and calcifications of the adrenal, on the differential diagnosis of that is histoplasmosis. So maybe this is what you get early, and then if you recover, eventually you may have calcification in adrenal glands and adrenal insufficiency even. So histoplasmosis, big surprise coming out of these adrenal masses. Anybody else seen this?
No, and I see histoplasmosis in about 30 to 40% of patients I see on a daily basis, and I've never, even in transplant patients, never seen at least macroscopic adrenal involvement. I've seen liver, spleen, and there was nothing in the lungs.
No.
Because that's the portal of entry too. That's very odd.
Yeah. Okay. So,
do other granulomatous infections, well, other than tuberculosis, affect the adrenal gland? Because we've seen it in a couple cases of miliary TB where on pathology they'll have adrenal insufficiency. It usually doesn't show up on imaging.
Beats me. I mean, there's a little bit of lymphadenopathy here in this fellow. Some hilar and mediastinal lymphadenopathy, but it's pretty not. But it's not normal, but it's not gross, and it's not caseous or anything like that I can see.
Yeah.
Okay. So, and then here's a person who has a febrile illness and weight loss, and this fellow is maintained on infliximab and methotrexate for his Crohn's disease. He's a nursing home person, and he has this progressively worsening chest radiograph here. At this point, he's got some lymphadenopathy and has some lung consolidation. here, and here's what it looks like on a lung window. We've got this focus up here, which is potentially fungal. It looks like an infection. There's a lot of surrounding edema. And then there's also some low attenuation lymphadenopathy in this person. These nodes back here. And so some consideration was given to tuberculosis in this. And then he grew histoplasmosis.
Really?
So, yeah. Now the first guy was an attorney who had been in Indiana in May, and then was in Italy when he got sick. So he was in Italy in July or June and into July, and he was treated here eventually and he turned out to have histoplasmosis. This guy who was on his immune compromise is his infliximab and methotrexate for his Crohn's disease, and it turns out he is from the Midwest. So this may be reactivation in this fellow of histoplasmosis. So it presented as this low attenuation lymphadenopathy in the lung lesions, and as another case of histo. But I don't think he'd been in the Midwest for a long time. The thing that confused this guy's history is that he also works as an earthquake retrofitter, which means he's working around and he's going around in crawl spaces and things like that, and improving the foundation of buildings here, because you know, we don't get a lot of earthquakes here, but they're waiting for, you know, the magnitude 9 to hit this area anytime. And so we've had earthquake retrofitting done on our house, and those guys spent days in our crawl space bolting the house to the foundation. So with that sort of exposure history, people were thinking about picking up, you know, fungus from soil and things like that. So you could get cryptococcus in that environment. If there are bird droppings, you could even get histo. Even in the Northwest, bird droppings can have histoplasmosis. So this is another case of histo, not the first fungus we think of in this area.
Yeah, I like your reactivation theory, because usually when we see primary histo in immune compromised patients, we tend to see it as miliary disease. Because they inhale it and it gets bloodborne right away, versus reactivation, it's sort of already in the lymphatic system, so you might see it in lymph nodes, spleen, things like that.
Okay.
Why do you think he has so much lung edema, interstitial edema? It's pretty florid.
Yeah.
Maybe it's unrelated. Maybe it was just fluid overloaded or something, and it's unrelated.
Well, this guy was pretty ill. I don't know how much fluid they were giving him, and you know, he had a weight loss, and I think he might have been hypoproteinemic and things like that. You know, he was pretty ill. So I just wondered if there was a lot of volume resuscitation, and he didn't have enough protein in his blood to hold the water in his bloodstream.
Wow.
Okay.
That is a surprise.
Okay. Thank you, Dave.
Those are my cases, Jeff.
All right, the fungus among us.
Well, taking those agents, infliximab and so on, that's a risk, boy.
Yeah.
Yeah.
You are exposed to bad infectious agents and you're on those drugs.
We've seen histo reactivate in HIV as well.
Yeah, that's when I've seen it cavitate when it's reactivated, which is, you know, very uncommon. When I see what looks like fungus that's cavitary, I start thinking about blasto and cocci, and a lot less likely histo. But when it's the cases of reactivation I've seen have often involved cavities, kind of like TB. Okay, Brent, I see you're on the line. Do you have any cases this week?
Maybe Brent is muted.
He's muted. I just was seeing if he's going to turn off his mute. Okay, well, I just have one to show, and I'll go ahead and show that. Some of you have seen it. Find it here. All right, so this was an anatomic mystery to me, but Travis figured it out without even looking at it, just based on my description. So one of my colleagues was reading this CT, and I think this was just a routine trauma from like fall from standing, something really not traumatic. But what was noticed were these. Let me make it bigger. You guys do see a CT, correct?
Right.
Okay. So there's these arteries. Here's the subclavian artery, and there's a little trunk coming off here, and immediately we see the internal mammary or internal thoracic artery. But there's this other branch that comes off laterally here, and it runs right along the inner surface of the chest wall. You can see it right up against the rib there. It's extrapleural. And it's not a very big artery, but we see them in this patient quite well, probably to about here. And you can still follow it down, running here anterolaterally at about 10 o'clock or so. And then it kind of just starts getting smaller and smaller. And interesting, if you go back, he's got one on the other side too, doing the same thing. So here we have the subclavian artery. It has a trunk. There goes the internal mammary or thoracic. And here's this lateral branch. And we haven't noticed it before. And, they are very small, and these are probably bigger than normal. And I looked very closely today on the few contrast studies we had and didn't see them. And so this is the lateral intercostal artery. And Travis was kind enough to provide a reference, if I can get it to show. I got to change this so you can see. There we go. It's an accessory thoracic vessel clinical interest. And I won't bore you with the whole thing, but what I found really helpful was probably this image here. So let me get this page. Right here, where you can see it running sort of down vertically along the ribs. And it becomes important in the case of a bypass, where you have a left internal mammary graft. And I'm going to change it. See this. Let me show you this again. You imagine you have a lima graft coming off the left here and going to a coronary artery. And meanwhile, for some reason, you've got vascular disease elsewhere. You can get demand that could steal from that trunk, and so you could get a steal phenomenon, stealing away from the lima to supply this chest wall. Say you had some lost intercostals because of sternotomy or other things like that, or someone gets revascularized and now they start doing cardiac rehab and lifting weights in the gym and doing things like that. So it's something I've never just noticed before. If I have, I've never thought about it. So next time I see our thoracic surgeon, I'm going to ask him about it, because I wonder if it affects how they, I guess it'd be, if you weren't being careful, it'd be easy to go through one of these with a VATS port or a trocar or something else and get into a little bleeding. So I don't know. It sounded like Travis had heard of this before, but I don't know if anybody else had any experience with this artery.
So there was a case at Barnes where there was steal phenomenon from that. That's why I was familiar with it or had heard of it. And
Jeff, does it have a common origin with the internal mammary then?
Yes, they come off the same trunk, off the subclavian. You can see it up. I can see it right. I can show you right here. So here's the little trunk, and it splits into two. And going medially is the internal mammary, and going lateral is this lateral intercostal.
Yep, comes right off there.
And you'll see that the internal mammary is a much larger vessel, but in this patient, this other vessel, and it sounds like it's an accessory vessel, it's fairly sizable in that we see it. So it's one of those things I have to start looking for more and more, but I don't know how frequently we encounter it on CT, because a lot of these anatomy studies are based on cadavers, which may not include as many patients.
I think I see it a few times a week, and you can even see, you can even see it on non-con CTs when you'll just see a little indentation that runs laterally there.
Okay, yeah, I bet. Oh, I see. Like you'd see something right like this, maybe.
You see a little bump that goes vertically there. Yeah, it's surprisingly common, because I had, the first time I saw it, I was like, oh, I've never seen this before, and clearly I had overlooked it dozens of times. So yeah, I bet. Yeah, I don't, maybe not a few, but at least once a week. It's pretty common.
Well, I will.
Okay, let's start looking for them and see how many we can find in the next 1 year.
Somebody will see one this afternoon.
Yeah, that's how things work. Exactly.
Probably
5 to 5.
I think they're bigger. They're a large and important artery in quadrupeds, in other mammals, more than in humans.
Yeah, that's what the article kind of mentioned.
Lateral costal, wow.
Because it has to do with the different shape of the thorax. Our thoraces are wider than they are from front to back. You know, in a lateral dimension, I think you get rounder or more kind of the opposite in quadrupeds, probably because gravity has a lot to do with it. But if you think about a dog, they have a narrow transverse diameter of their chest and a rather longer AP diameter.
So where does this vessel, where does it dump the blood? What's it supplying?
My thought is it probably bridges a bunch of intercostals.
You think it connects to intercostals then?
That's what it looks like. It looks like it sort of, piggybacks them, just kind of like, when they have to take all the side branches off the lima, that's why you see all the clips.
Right.
So I think it's the same thing.
Uh-huh.
David, didn't you show a CT of a dog at some point? Somebody did, didn't they?
I showed one that had a congenital heart disease.
You should look and see if they have big lateral costal arteries.
I do have a CT of a dog from a couple of weeks ago with a left upper lobe lesion that might have been a pneumonia, maybe from a central lung cancer. Did I show that in conference a couple of weeks ago? I'll show it next time. Pull that out.
I was thinking years back. So, yeah, you should pull it up and see.
All right. Well, that's what I have. Travis, do you want to show some more?
Sure. All right, this one has a nice radiograph, and I'm not sure how much there is to learn off of the actual diagnosis. But this was an outside radiograph, and the interventional pulmonologist came in and asked us what we thought about it, and gave us the history that the patient had some upper airway symptoms. And sure enough, that looks like there's a little hump extending into the airway there. And I don't think it's nearly, with the humerus and stuff overlying the trachea, I don't think you can really see it on the lateral view. This looks a little peculiar back here. It's a little high for where you would see the azygos arch. But there is something there, and you can see it right here. And so it looks like it's an airway tumor. She doesn't have a history of a cancer, so you'd go down the squamous, maybe lymphoma or something weird. But this actually turned out to be Rosai-Dorfman disease. And so like I said, I don't know if there's much to learn from that pathologically and say this is Rosai-Dorfman disease, other than this is Rosai-Dorfman. So, and I guess I've never seen it involve the trachea before. And I think David showed a case a few years ago where, you can have it both nodal and extranodal. So I don't know if you'd define this as nodal with extension into the trachea from a right paratracheal lymph node or extranodal disease, but that's what this turned out to be. So,
wow.
I don't know. I don't think I'm going to be including this.
Yeah. Sorry, no involvement of any other organ in the body? Brain, anything else? No, just the trachea?
So yeah, just the trachea. That's the only site. So.
You think it's really trachea, or do you think it's mediastinum going into trachea?
Oh no, I mean it's involving the trachea. Yeah, I think it's probably right paratracheal.
Mm-hmm.
That's why I think it may have been nodal, just from the right paratracheal going into the trachea. But there was definitely a an endoluminal lesion that they were able to debride out most of. So I don't know. I didn't get a chance to read up and remind myself on Rosai-Dorfman, other than I know it's a nodal histiocyte proliferation. So I don't know if anybody else has it more fresh in their mind and wants to remind everyone of what it actually is. But I just thought it was a nice radiograph, and the pathology is, and it's probably a good pathology for the patient, as opposed to a squamous cell or something else.
Wow.
This one, again, another nice radiograph. And this one's kind of a showstopper radiograph, where you see that the heart is big and then you just have massive pulmonary artery enlargement. And this is a lady that has a known diagnosis, but I know I've shown cases of this before. And whenever I see PAs this big, the first thing I look for the curvilinear calcification that you see here that would be indicative of most likely atherosclerotic calcification in the pulmonary artery, which is what this is. And so, of course, this indicates that she's had long-standing pulmonary arterial hypertension. And often when you see it this severe, that you think that it's probably a long-standing shunt. And so I'll show you, here is the, here's a coronary CT they did, and we'll get to the reason for that in a second. But I always think it's fun to look at the timing series, like I've shown cases before, because it explains the physiology. And notice that SVC, and then almost instantly you see pulmonary artery and aorta at the same time. And so sure enough, she does have Eisenmenger physiology and cyanosis here. And you can see the aorta's lighting up well before the pulmonary veins do, and well before blood's actually getting back to the left heart. But the reason they did this, and I think, Jeff, you may have shown a case of a pulmonary artery that was this large that was impinging on the left anterior descending coronary artery. That was why they did this study. And it actually isn't, she actually still has room here. It's not compressing her PA. But that was why they did this study. And it shows you a nice example of just this massive secundum atrial septal defect that she has. There's basically no interatrial septum in this case. And you can also see the atherosclerotic calcification in the walls of her pulmonary arteries from just long-standing pulmonary arterial hypertension. But what's also interesting about this is that she had an old study back in 2008. And check this out, at the time in 2008, she had a lot more mural thrombus in her pulmonary arteries. And she had a little bit of flow artifact there too. But I think it's really interesting. She was on anticoagulation, and they didn't know if she had chronic PE. I think this is probably just in situ thrombus, but it's pretty impressive that improved like it did. So I think that's I thought that was kind of interesting, and it's nice to have the correlate from a few years ago to show that. So
there's another nice indication here of a left to right shunt, and that is the small size of her aorta, because there's not that much forward cardiac output. It's all going around and around, on the right side of the heart and out to the aorta. So her aorta is fairly small for an older person.
Yeah, that's a really good point too, because it's 2.5. So she would have to be a really small person for that to be normal as an adult. And I think the pulmonary artery was 7 or 8 or something close to that, 6.5, almost 7. So, but nice radiograph, nice teaching case with all these findings.
How does her lungs look? Does she have any of the findings described with pulmonary arterial hypertension that's chronic, the so-called neovascularity, etc.?
Yeah, thank you for. I'll go back to this one because we didn't have the full images. And I think she does have pretty big tortuous peripheral vessels. She doesn't really look like she has a lot of the centralobular ground glass or the real profound centralobular mosaic pattern that we often see.
No, not really. Maybe very slightly.
Maybe a little bit.
Yeah. But that reminds me, actually, now I'm going to have to put on these diagnoses to find this other case that I wanted to see. This one. Speaking of which, Howard, I'm glad you remind me because I almost forgot to show this case. This is a patient who, this is another one of those cases that you could spend an hour teaching with how much stuff is going on with him. But this is back in 2006, and he has known pulmonary hypertension, and we'll get to the classification in a moment. But this shows the value of expiratory images, as he's one that this looks like it should be ground glass, and the rest of the lung is normal, except you see really diminutive vessels in the other areas. And this is very geographic. And if I can find another study before I show you the expiratory images, let's see, this was from 2006. 2008, I think is when he had another study. And you see that the distribution of this is identical. So it was not some sort of acute crazy paving, some sort of viral pneumonia or something. And so this also clues into the fact that this is mosaic perfusion. And I do have expiratory images on this. And you can see just how it's not air trapping in the other places, that this is all mosaic perfusion from vascular disease. How all of on the dynamic expiratory, how maybe a little bit of air trapping, but how everything else gets more gray like it should. So this, I know Brent showed a case of obliterative bronchiolitis from graft versus host disease with this striking pattern like this of the ground glass, you know, looking like ground glass, but actually being areas of normal or even hyperperfused lungs. But this is another case. This is the best case I've seen due to small vessels disease. And so that gets to the question of what his actual diagnosis is. He's a chronic meth user, and so he has had a combination of both group 1 and group 4 pulmonary hypertension, so pulmonary arterial hypertension, plus chronic thromboembolic disease, we think at least. On one of these studies, and I can't remember which one it was, he did have some pulmonary emboli. I think it may have been this study where he had PEs. Yeah, he had some pulmonary emboli here. So he'd had history of pulmonary emboli as well. He underwent lung transplant, and they thought mostly on pathology that it was just group 1 pulmonary arterial hypertension. Didn't see any real chronic PE clot, and I don't know. I think we could debate both of those. But then he undergoes lung transplant in somewhere around 2010. 2013, he looks okay post lung transplant. Then he's lost to follow-up, comes back earlier this month, and so now he has profound upper lobe volume loss, elevation of of his hyla, and so now he has pleural parenchymal fibroelastosis, has restrictive allograft syndrome as a manifestation of his chronic rejection now, and he's back to using meth as well. So what do you guys think about the PE versus group 1 pulmonary arterial hypertension? I thought I had a report on him, but maybe not. I guess I didn't copy it out of his chart, but I mean, these large areas of mosaic perfusion certainly would argue more for chronic thromboembolic disease rather than group 1 pulmonary arterial hypertension. But when they did the explant specimen, it looked more like the plexogenic arteriopathy.
Yeah,
I don't know.
You know, the distribution of the ground glass is it doesn't look thromboembolic to me, just by the way the ground glass stuff is distributed, or the abnormally black lung is distributed. It's not in the large vessel territory. I mean, it's not pizza slices.
Right. But it's not a great look for group 1 pulmonary arterial hypertension either, because it's not central lobular like we normally see.
Right.
It's kind of interesting. But at least we have the expiratory that clearly shows it's not air trapping and it's not an obliterative bronchiolitis in these cases. So I don't know.
It's just a very strange distribution of increased pulmonary vascular resistances where you have, in those small vessels, the black lung, you've got to have very extensive small vessel disease with high resistance flow. And then the flow goes to just relatively circumscribed areas of lung.
Right.
It all comes to a few relatively small areas.
Yeah. And
does his meth use, is there a pulmonary hypertension associated with that? We've
seen dozens of patients with group 1 pulmonary arterial hypertension from methamphetamine use.
Okay.
So I think it may be along the same lines as fen and the other drugs that have been used in the past. But yeah, we definitely see quite a few patients referred for transplant because of that. So it's kind of shocking how many we see. But yeah, it's interesting, but I mean, it's definitely a great example of expiratory. So
yeah.
But
yeah.
Okay, well, I will stop there since it's almost 1 o'clock.
All right, well, thanks, everybody.
Thank you.
Great case.
Thank you very much. Great cases. Thank you.
Thanks. See you next week.
All right.
Okay. Bye-bye.